hasn't it? Interesting announcements, some pretty significant announcements as well. And for this session, I've basically been asked to come and talk to you about whatever you want to talk about and about the conference and various other things that are happening in general practice. So I'm going to cover a couple of big things that you probably have heard and may not have heard in the past few days that have happened in general practice. And I'm going to open it up to the floor. And you guys are going to have the access to this microphone to ask me questions, and we'll figure it out from there. And we've got 45 minutes, so hopefully this will be an interactive, fun session tackling everything when it comes to tech enhancing primary care and learning. So, like I said, we're here at Accurx Connect, and as a result of the conference today, we've heard this big announcement about the partnership between Tandem and Accurx bringing AI Scribe to general practice. I mean, that's going to change things. You know, we're talking about a company that has significant market share, bringing a technology that we know can potentially have huge impact in terms of how we work in general practice. So much so, if you didn't know, a couple of days ago, NHS England released some documentation about the use of ambient voice technology, or AI Scribe as I like to call it, in terms of healthcare and the potential impacts this will have. We know from Wes Streeting in his repeated comments about analog to digital, that's one of the methods that government do see that we will be able to help patients have more contacts, streamline care, and hopefully make the NHS work more effectively. And Ambient Scribe in particular is going to be one of those tools that potentially helps to make that journey happen. But up until a couple of days ago, we had very little guidance about what that means. So, quick question. Has anybody read the guidance? Okay, don't worry. Actually, a lot of it is very common sense. It's stuff that many of us knew about the use of AI technology in healthcare, just reiterated, but more importantly, made clear for those of you that do want to use these products in terms of what you need to consider and look at before you start using them. Key take-home messages, a lot of what's already been covered today. Number one, you need to do the documentation. Things like the DPIAs, things like the DCB 0160s. These are documentations that look at how you use technology in healthcare, okay? And some of them are legal requirements for you to do. The problem is many of us haven't thought about it because it's a relatively new legal requirement. And it's not something we've had to do up until recently. But these are really important. And what's really powerful is using tools to help you do them. You do them quickly and effectively and safely, okay? Weirdly, you can even use AI to do that. Yeah, things like ChatGPT and that kind of stuff can actually help you do a lot of the documentation. Just key thing is, as with everything with AI, check it first. Okay. There is also recommendations that you have something called a clinical safety officer working in your practice to manage the documentation as well as the use of those tools and what that looks like. Now, that's the part I think some practices may stumble at because they'll say, well, I don't have a clinical safety officer. And it is different to your Caldecott Guardian role that you will have in practice as mandated by law. But that's potentially where the providers can help you look at these tools to figure that out, as well as potentially looking at things like your PCNs, your federations, to help manage some of that risk for you to make that process easier. In addition, there's been this key aspect of training. One of the things about new tools is a tool is only ever as good as how you use it. Yeah, so it's making sure that you've got that training built in for how that will look and work in terms of your practice and your area. And lastly, as ever, understanding the consent process for patients, particularly when it comes to ambient voice technology. We heard earlier in the demonstration how you can consent patients. You know, there is absolutely the use of using things like your DPNs, your data protection notices, information in your waiting areas, your practice websites, but also taking that step with the patient in the consultation. I'm using this tool. Are you happy for me to use that? I've been using these tools for almost 9 months now. I've had 2 patients say no in that time. I probably see about 100 patients a week, give or take, maybe more. I don't know. All blurs into one after a while, doesn't it? But that's the volume that you can see, and that's actually the number that often actually want more information. Yeah? So it's really easy to do, and I highly would recommend looking at those. So I guess at this point, I've done a little bit of talking. Any questions on ambient voice technology, scribes? Have we done such a good job today that everybody has all the information they need? So you're all going to start using it as of tomorrow then? Woo! Yeah, absolutely. Okay, job done then. I was not expecting that. Okay, So those of you who are watching online as well, absolutely you can ask your questions. We've got some people helping to figure out those questions as they come through, and if they do, we will answer them as well. Okay. So let's move a little bit of focus into what else can be happening in general practice. About a month or so ago, we had the new GP contract. Now, significant potential investment coming into general practice, maybe not in the way that many people hoped, and whether it's the uplift that we needed. I think even the GPC will admit it's not where we need it to be, but at least it's turning that big tanker in the right direction to where we possibly need to look at. There is obviously an increase in investment in terms of global sub and tackling some of that aspects of the NI and national living wage that we've got coming through. But there are also some significant changes, and I guess the one I wanted to talk about was the QOF stuff. So who here is involved in their QOF stuff in practice directly? How many of you think that this is going to be a huge amount of work for you for the next year or so? Okay. So if you don't know, the big changes with QOF is the fact that actually quite a few of the identifiers have been reconciled, so you don't have to worry about them. They're the registers. Okay, that's not a big thing. It's just money that's guaranteed almost. But there is that question of actually by not keeping the registers, is that going to affect prevalence? That's an interesting part. The big one is obviously around the cardiovascular and lipid QOF in terms of those the criteria being much higher, as well as the number of points that they're worth considerably higher. And I think the reason why that's really relevant from all the modeling that people have done so far, if you do exactly what you did last year, you're going to make a loss. So it is that question of how in practice are you going to tackle the QOF markers to make sure you don't have that loss moving forward. I think there are a variety of tools you can absolutely look at, some built into Accurx in terms of the patient flow, the florries, that kind of stuff that you can use. And we've heard today about some other tools potentially coming through that may help with that even further. I think there are other tools that you can look at using, but I think for me, the key thing is also having an eye on that now. Yeah, the hypertension aspects of that cardiovascular stuff, you can potentially catch up in January onwards. It's going to be a huge amount of work, but possibly for the cholesterol aspects, you need at least 3 to 6 months before to get that into criteria. So that's stuff you do have to do now. So if you thought QOF season was over, I'm really sorry. It's just beginning again. And that is realism that you need to consider when it comes to that finance aspect of your practice. Because if you don't, this is, well, like I said, if you do exactly what you did last year, you're going to make a loss. Yeah? I'm seeing a lot of nods and yeses and that kind of stuff. Any further thoughts or opinions? I'm kind of hoping somebody jumps up. Come on. Yes. Okay.
The requirement to have your online tool open about 4 hours.
I was going to come to that, so don't worry. Yeah, I'll come to that one a bit later if that's all right. Yeah. Any other? Yeah.
Last year and the return.
Okay.
So, it might be recommending what
Absolutely. So absolutely agree. I think there will be some practices that have no problems whatsoever. I think majority though, when you look at the criteria, because the uplift that with the changes in the percentages you need to achieve, that actually majority of practices, if they did the same thing, they will make a loss. Now, the key thing is that you don't do the same thing. That's the aspect. Like I said, it is things that practices need to look at now and start looking at, particularly areas of multi-ethnicity and deprivation. Actually, those are the ones that are really going to struggle because they have that engagement aspect challenge that comes with it. So it's those populations in particular that will have difficulties, particularly those, again, with high mobility patients as well. So where, obviously your patients are registered 1 month and then next month they move somewhere else, and that's where those practices will really struggle because you won't get that continuity to tackle their long-term conditions in the same way. I saw a hand somewhere over there. Yep.
If I ask you do a summary or show me guys what's different this year, what would you say? What's actually different?
As in QOF, so I can't remember all the exact numbers off the top of my head because they are quite significant. I'll be honest, even without my notes, I couldn't remember. But I know that the cholesterol and the hypertension QOFs, all of them have either gone up in terms of percentages by at least about 15 to 20%, and the points value of them has also gone up quite considerably. So some of them, I think one of them's gone up by 30 points almost. So obviously, depending on how much each of those points is worth in your practice, because if there's ever prevalence changes that for each practice, there are potentially significant sums of money that you may lose out on as a result of that. Got a right creaky door, haven't we? So they're the main ones in terms of financial, and then obviously the other big change to QoF was the asthma diagnosis guidance and the shift away from spirometry, moving to Pheno as well, which potentially is quite useful unless you don't have access to a Pheno machine, which, let's be honest, most of us don't. So another hand over there. There we go. Yeah. Yeah. Absolutely. So absolutely, the thing about AI is it's now you've got a third person in the room, and you need to think of it as that way, because actually by doing that, you get better quality of the documentation. If you did exactly what you probably did before, it will help, but you won't see the real value of it. So verbalizing what you're doing, that has an impact in terms of it capturing that information. You saw in the demo about them talking about, the visual findings in terms of the signs, and then also talking about the metrics. So, talking about the temperature. Your temperature is 37.6, your blood pressure is 112 over 80. Those kind of things you have to verbalize to get the most use of it. But it has another impact by doing that. The patients start thinking you're actually paying attention to them. That's the weird thing, because you're then having to say it in a way that makes sense so that the system can capture it, but the patients are then listening to you as you say that. So actually, for me, one of the things I found is that the patient's like, oh, thank you for explaining that to me. I didn't actually mean to explain it in the first place. I just did it. And it's really powerful in terms of that patient engagement because you're doing that. And one of the things I found particularly, safety netting, huge benefit in that, because I'm actually not just safety netting, but it is then capturing all that detail of what I've safety netted as well. And for me, from a medical legal perspective, that's really powerful. But I know that what I've set up for what I use, I've actually asked it, every time I repeat something, I want you to make sure you put it down verbatim as what I've said. Because generally speaking, if I've repeated it, it's really valuable to the consultation. And by doing that, the notes are so much clearer, better from my perspective. And also from the patient's perspective, they get a full visualization that we heard as well about how patients now increasingly have access to their records. And as a result of that, that information flow is much better. Yeah, thank you.
Sorry, just going back to Pop for a second. Have you used AI or any tips or tricks to improve challenge reviews?
If anybody's found that out, I would love to know. So I've been quite public that I think that the child and IMS QoF side of it is an absolute travesty and intentionally designed to make those practices in deprivation fail. And, I'm more than happy I'm on camera right now saying that, so I know that. And repeatedly, I've said that NHS England should change the exemption rules because the reality is it's designed to be a challenge. If you live in an area of mobility where patients come from other countries, it is almost impossible to make that IMS QoF work and actively penalise. And then it raises the question, why would a practice want to do all that extra work if they know they're not going to pay for it? It's great if you've got enough time to be that altruistic, but let's be honest, we don't. So I'm afraid I don't have a particular tool. I know there are some tools out there to help find those more specific patients. I mean, you can get that from the list anyway. Potentially, you can use other methods like social media campaigns and that kind of stuff. They are significantly time intensive. And part of the challenge is, I absolutely get for the vaccine hesitant trying to encourage them to have it. But when you've got that additional challenge of patient mobilization, or the fact that they've had their vaccines in other countries and they don't track across, that's even more frustrating. It just demoralizes you, doesn't it? And that's the frustrating part of it. So actually what does need to change, they do need to bring back exemptions for vaccines, but obviously they don't want to. And they've repeatedly shown that because they've had the opportunity 3 years in a row to change it and they haven't. Sorry, high horse there. Apologies, everyone. Go for it.
Going back to AI, there are 2 questions. First one is, with this new guidance that has been brought out, there are areas of the country where it's an absolute no to use AI in general practice, safe, and there are places where there's an uptake, even if it's checked. How does this guidance, how does it change the game for people that use it? Do they need to do anything differently?
So the guidance that came out a couple of days ago, I think solidifies what people should and should not be doing to install the use of ambient voice technology in their local area. It sets a roadmap for you being able to do that. So for those, I think actually a lot of those no's we've heard before will now start to turn to yeses as long as that work has been done. Key point to realize, there is nothing preventing you from doing that in your practice now, as long as you have done all those governance steps. The difference is, if you want your ICB to give you approval for them to pay for that technology, for them to do that work for you, absolutely. They have the right to turn around to you and say, we're not doing that, because it is a lot of work. It's a lot of time. And actually, I can't fault some of them for saying no, because actually that is so much more work for them to do. But if you wanted to do that, there is nothing stopping you from doing that yourself. And actually, those practices where they have started to do that, they've recognized that, they've taken that work on board, and they're seeing the benefits of being able to do that now because they've already done a lot of that pre-work. Some of that can be shared. The providers themselves can share some of that with you. Some of that can be copied, used. It still needs to be done by yourself because every practice is so different. There are always going to be different aspects that play into it. Not massively so, but it's a little bit of work, to be honest. But to be clear, there is absolutely legally nothing preventing you from doing it as long as you've done the safety work first. If you just start using it without doing that, on your head be it. Does that help? Yeah.
I presume there are some of these scripts that record the conversations and store it on their servers that allow what's the individual implications of that.
So that is a part that's worth going back to the provider and saying, so the question was about storing and keeping the transcripts and stuff. So yeah, there is a key part of that is the question, should they be storing them? So a lot of providers say they don't. So if they're saying they don't, they shouldn't. So it's worth checking that. We heard earlier in Amar and Fari's session about, how actually if you've done the DCB 0160, the 129s, all the payment documentation, if they're saying they don't store them, they shouldn't be storing them. End of story. And if they are, on their head be it. That's an issue. I think, should we be storing data? There's no specific need as far as I can see to store the data, because the whole point is it's transcription live and then summarization that works. There are, I guess, potentially some benefits you can have in terms of case analysis, looking for faults, and potentially other aspects. But I don't think it's a necessity part of ambient voice technology to be able to store the consultations. It just gives a different perspective of how you use it. Yeah. Okay.
Just a question, a reflective question based on what you said. The historical piece of software that we use in practice that predates EMIS, document, cloud telephony providers. I don't know whether we have DPIAs and stuff.
So weirdly, we should. And imagine doing your DCB 0160 on EMIS right now. Yeah, would it pass? I don't know. But this is so there are absolutely challenges in terms of the technology we have, and some of that we've used because it's felt to be safe and utilized and things. I think, as ever, when something new comes in, there's that hesitation, there's that question about should we use it, shouldn't we use it? And that will happen with every piece of technology coming through. Loads of attention is paid to AI and hallucinations and its errors that it makes. But let's be honest, we're humans. We always make errors. What's the error rate of a person on their 30th consultation of the day not remembering to write something down? That is just as high or probably higher than most AI platforms in terms of transcribing information correctly. So I think there is some element of consideration placed into that. But because it's an extra tool, because it's new, because it is technology, I agree there needs to be those safety parts in place. As long as you paid consideration, as long as you've got the things in place to understand how that works and how to mitigate it, that's fine. Yeah? Okay. Yes, at the back. No, so you will probably have to, so the question was about your existing DPI, will it track across? Because ambient voice technology is a different way of using that technology, it will need to be refreshed. Do you need to do it from scratch? No, you probably just need to add in some extra bits and stuff, and that's where, absolutely the providers can help you find the bits that you need to change and adjust and things from there. Again, it's that question of, the thing about the DPIAs and the DCBs and all that kind of stuff, it is a safety risk assessment. That's what they are. As long as you've done them and you've done them relatively sensibly, that's fine. The key thing is, A, if you haven't done them in the first place, then there's that question of, have you paid attention to the possible risks of using that technology? And therefore, how do you know what the risks are? And as ever in general practice, we are the masters of assessing risk, let's be honest. We just kind of need to do it with the tools that we use as well. Okay. Yes. Online question, yay! That's made me really happy.
It's about the cost of it.
I'm afraid that's not something I can answer right now. I am planning on asking Jacob that very question, so hopefully you will see the answer to that later on. I have told him I'm going to ask him that, whether he likes it or not. So we will find out if he answers or not at that point. What I will say is, the cost for me, no matter what the platforms are, when you are sitting in practice at 7, 8 o'clock in the evening, thinking, I wish I'd gone home sooner, and you're not using an ambient scribe technology, I would argue you probably would have gone home a little bit sooner if you had. Okay? And that for me is worth anything. Right, we had a question earlier about the 8 to 6:30. Yeah, so this is one of the other big changes in the GP contract. And as many probably know, it was a red line item. So everything was pending that being agreed upon. And it is a change. It's a really subtle change. The interesting part of it, so for those who do remember, as part of the PCN CAPE payments, actually, PCNs had to agree that their practices did have an online route open from 8 till 6:30. The difference is, in terms of the new contract change, it's very much semantics, but it is about medically non-urgent requests being available all day, okay? So before, you just had to agree that you had online consultations open all day. Now it's specifically around medically non-urgent issues. Now the slight problem with this, anybody have any idea what a medically non-urgent issue is? Because I don't. I know a lot of our patients don't. Because actually that's a perspective. My perspective of a medically non-urgent issue will be completely different to a patient's perspective of a medically non-urgent issue compared to the next patient and the next patient. I know many of my patients who will say that their fit note is a medically urgent issue. So how are we going to figure that out? I think this is actually one of those points where we will be turning to our providers to say, how are you going to help us with this? Because absolutely, this is an issue in terms of the intake of the information that we're getting from patients. I think there should be a button switch when they come to access us through the digital portals to say, is this a medically urgent issue? Is this not a medically urgent issue? At least giving the patient some responsibility. Now, let's be clear, some will get it wrong. We know that's going to happen, okay? And some will say it is urgent and it's not urgent. Some will say that it's not urgent and it is urgent, etc. That's life. Again, we're humans. We make errors. And nobody can predict the future, not even me. But the whole point then needs to be that inflex point to give that potential option to patients. The question then of how practices manage that's a little bit more trickier. Now, hopefully you've all been to some of the other sessions talking about total triage and other kind of methods that you can use to manage demand in practice. The difficult part with this is that, as ever, it'll be a practice-based decision, because what you've got in your practice will be completely different to what's in my practice or what's in the next practice to manage that workflow. So I'm afraid if you're hoping for an easy answer, there isn't one. But the key thing is start thinking about it now. Don't wait for October, because doing it with a week to go, it's going to be so much harder than thinking about it now whilst you've got 5-6 months to figure out how you're going to manage this challenge. And it is going to be a challenge for some places. I think there are some places it's not a problem at all, but that's the minority, let's be honest. Anybody else got any perspectives on that? I would love to hear your views on that particular part.
I can show what we do currently, and
yep.
we use Accurx Connects, so we tell part of currently. So we know our demand for the day, and we have points allocated to manage that demand in the afternoon. The problem we have is that we have to open the store all day long, but we have clinicians triaging throughout the day. I would love for parents to create some sort of a waiting room that involves patients that they can put their request in, but it may not get seen to the next day. Now, I suppose there's an issue of accountability there. Once that request lands in your mailbox, whose accountability is it?
True. I think there is, correct me if I'm wrong, there is some of that functionality already there, that the patient's informed that this may not be seen till this amount of time at least, and it's recognizing what amount of time the practice feels is sensible for them. And I think that's very much different based on whether you do a total triage model compared to whether you do a hybrid model compared to whether you do a different type of model. I think there's also the flash ups that come up that say to the patients that actually these things don't come to us, go somewhere else, because actually you should not be dealing with them and stuff. But I think the harder part is, like you say, what do you do when you hit the capacity? Because that's the part that no one's really thought about. Everybody has a capacity, and there are some places where they're amazing. They've managed to create capacity that seems almost unending. Yeah, there are some places where that capacity, no matter what system you use, is gone within 5 minutes of the practice being open. Yeah, but it's how you manage that capacity, and there is an element of managing that risk. I think we will see the start of waiting lists in more and more practices, and that's one of the things the BMA recommended in terms of their guidance about safe working. I think we'll probably see the increase of that as we move forward. I think, look at the videos from Amar and Fari about, the whole RAG rating system for how you use a triage system. I think that's really powerful. They've got some amazing videos out there, to help understand that concept. And if that works for your practice, absolutely look at using it, because actually what you want to see are the reds on the day, manage the greens and the ambers, fit in where you can as best as you can. But, it is having that consideration and having that plan to how are you going to start tackling it moving forward. I think many of us are still going to be anxious about the 8 to 6:30 open aspect. And, what do you do with a request that comes in at 6:29? I mean, should we be waiting there till 6:30 on the dot to go click? No. But that's not, I don't think that's the point of it. And I think having fed back to NHS England directly on some of this as well, there is that recognition that, what is a medically urgent thing or non-urgent thing? That's always going to be different. Yeah.
I mean, I don't know if this solves the problem and stuff, but we use an AI triage tool that automatically triage patients without human input, and that's very short time. It can be the endpoint being of the appointment to a so that fulfill the contract, you think?
So the key point from the contractual aspect is says that your system has to be open. As long as your system is open, that is all that matters. It doesn't say you have to offer them an appointment between 8 and 6:30 on the same day. That's not what the guidance, that's not what the instructions say. It simply says that your online system needs to be open from 8 till 6:30 to take non-urgent medical requests. So actually, yes, that would fulfill the criteria from my understanding, and that should mean that you have no problems. Hey. Yes.
From my point of view, as a busy mother who's a GP, I can see why that functionality would be useful. But I'm interested to know why.
It's dead easy. It's a great soundbite, isn't it? We've made general practice open 8 till 6:30. Previous government didn't. It's a soundbite, and that's what the AM rush. They want that gone. That was the previous government soundbite, though, if you remember. 8 till 6:30 being available. You can contact your GP anytime during working hours, and they will respond to you. It's a great soundbite. And yep, Amar.
Suggestion for a garden request us quite a few times. When I'm on TikTok, getting some really sort of particular kids. Surely our form is on. We take much of the matrix something similar. And if you all plan for it and put pressure on Jacob,
I think Jacob's gone already. He said he was going at 2:30. But sorry, just before but I guess there is that question of we have amazing providers that help us in general practice, and they all have different skills and sets in terms of what they can provide and what they don't provide. I think looking at utilization for the value that the practices need and want absolutely is a great thing. And one of the cool things I'd say about Accurx absolutely is they listen to their users. If they ask for something, they generally deliver it. And if they can't deliver it, they're honest about the fact we can't deliver this. So, yeah. You're starting the form tomorrow. Cool. You had a question?
How do you work on avoiding duplication? Because what we had in the past is we were using different providers. We used to turn it on 24/7. So we used to get a lot of messages on Saturday, Sunday. Same for like patients has a habit of sending a message, let's say today at 3 o'clock. If they don't get a response, they send a home after 1 or 2 hours. So when you check, you're getting a 10 message or 11 message on Monday morning from the same patient. So what's the plan for those patients? Because once you open till 8 to 6:30, if I send a message for let's say UTIs or let's say off for 1 week or 2 weeks, I might send it 8 o'clock and I might wait for 2 or 3 hours. Keep on sending the messages. So does this system something has any options to avoid these things?
So we all have those patients that provide different challenges to us, and we absolutely, every practice will have some of those patients where they contact us multiple times a day, multiple times an hour, potentially, you know, and I think recognizing, first of all, who those patients are, you probably know who those patients are, and actually they probably need handling in a different way. And there is that aspect of saying to them that actually we either responding to them on the first one, saying we've got your request, we'll deal with it. So there's a question of, does that feedback loop get completed so they know it's been submitted and you're dealing with it? If that is the case, being clear in the time frame that you're going to respond. The next part then is, if it is being overused or abused, how do you as a practice handle those patients where that's a part of their challenge? Because they may have valid reasons, they may not have valid reasons why they do that, but they still do it. So actually as a practice, it needs to be a practice response as to how to handle those. And that could be, actually, we're just going to give them a phone call, because actually waiting for the issue to be dealt with, there's no point. It could be signposting to a planned appointment that they have in the near future, saying, actually, we're not going to deal with this, we will deal with this at your planned appointment that is at the date in the future. I think there are different tools you can use. I know there's great learning on the WhatsApp group and the Facebook groups about various situations like that. I would recommend having a look at those as well. But as ever, we're always going to have difficult patients, let's be honest. It's part of general practice. Any further comments? No? All right, I'm going to go on to the next topic then that I had in my head. SMS costs. I love the nervous chitter laugh that people get when you talk about it, because it's a weird problem that only we know about in general practice, because nowhere else in the world is this a problem. But it's a frigging huge problem, isn't it? So for those that don't know, obviously, every time we send an SMS, actually the ICB is charged approximately 3p per SMS fragment, reminding you that a fragment is actually 160 characters. So potentially you could be sending a message to a patient that's 5 fragments long, costs 15p. Not too bad, is it? Factor that by about 10,000 patients. Factor that by about how many patients in your ICB. Unfortunately, you're talking millions of pounds. And this is a growing problem that we know is coming, because obviously our ICB colleagues have got really tight margins they need to look at. So there is this question now about how we tackle SMS costs, and actually many places are probably already in a place where they've been given budgets or are actively being told that they're going to have to pay for those costs directly themselves as practices. And if you haven't had that already, I'm pretty sure by the end of this financial year that's going to come to you. There is this question of how we tackle that. There are various things you can do in practice, and I would highly recommend, if you have not looked at this, you start looking at this now, because what you don't want is a 300, 500, 2,000 pound bill every month for SMS costs that you'll suddenly have to figure out. That's you know, staff members' pay that you are losing because of the way that SMSs are being used in your practices. Now, does that mean there's easy solutions? Unfortunately not. There isn't, because let's be honest, an SMS to a patient is often one of the most cost-effective ways of communicating with patients about the majority of their health issues. Fortunately, the system doesn't recognize that, does it? Because it's a financial cost rather than an opportunity cost, which in general practice, we're used to soaking up the opportunity risk of the whole NHS, aren't we? But this is a challenge that unfortunately we are going to have to face as practices, and how we look at that moving forward is absolutely a key thing. We have some content on the EGP Learning channel if you want to have a look at that. There's some great content also by the Accurx team. They did a webinar video, I think about 2 months ago. Yeah, that goes through quite a few things. Quick hints and tips. Try and figure out your most frequent SMS message you've sent in practice, and make sure it's at least 1 or 2 fragments, if that's the case, not 3 or 4 or 6. I think 6 is the maximum, isn't it? Yeah. Because actually that's going to have an impact. I think there's also trying to transfer as many people over to email, and particularly for non-urgent care, using email rather than urgent care. I still think text message works the best for urgent care. there is no parallel that comes close. And the NHS app and notify mechanism, unfortunately, is just not great when it comes to urgent issues and stuff. Routine, no problem. Or your routine care, send through the app, send through the email, that's fine. But urgent care is still a problem and a challenge. And then maybe look at those behaviors that you have in practice with people sending huge streams of messages, because actually it's still not safe to some degree to send a message of particularly patient identifiable information as a first contact through an SMS. That's still a governance issue, to be honest. You know, should you be sending detailed medical information as a first SMS to a patient? Probably not, you know. So thinking about those mechanisms and stuff. Yes.
Just seeing a bit of a risk today, but it's right.
Mm-hmm.
The opportunity to send a message, send a message to the patient on the back of that right. Could increase the cost, but still is there an option to move that to the NHS app, or in London, especially the big conventions, the email side, I think it's a great opportunity to send messages by email, but a lot of clinicians like the idea of emails being a route to messaging.
I actually agree with you. I think if you're sending summary of the consultations for the patient you've had in front of you, actually the default being email should be the route in that situation, because actually you've just consulted with the patient. You're sending them a record or the information to follow up on the consultation. I think that is different to, from my experience, a lot of the transactional emails are the ones that are highest volume use. So it's the ones that this is how you contact us, this is where you get information about this service. Do you want to submit an online request? Here's a link to do that directly through our system. And then that being 20 characters long, and as a result of that being 3 fragments, and that's where the issues come into play for the majority of people. But I think there is that aspect of the follow-up. Yeah, absolutely, it should be email, because saying to the patient, if you want this information, here's how we send it to you, or we'll send it to you on the NHS app. Yeah. Oh, it's coming. It is coming. Let me be clear on this point. Every ICB across the country is looking at how they can cut their budgets. They will look at their SMS budgets as part of that. 160 characters per fragment. That goes down if you use a Unicode image in it. So if you use anything like an emoji or some of the special characters and stuff, it goes down to 70 characters. And then each character after that is an additional message. No, that's how the system uses it. No, so a text message fragment is 160 characters. That's a universal thing across the entire country. That counts. So it is. I cannot think of a way that you can send a link to a patient that doesn't end up being less than 2 fragments, because by default, any of it. So big fan of the flurries, but you send a flurry, that's 2 fragments minimum. And then if you add extra stuff into there, how to do it. One of my most popular videos is how to take a photo of your throat. So what I do to all my patients is I send them a text message with a video link of how to take a photo of their throat, and then the link to send the photo back in the same one. Unfortunately, that's 3 characters unless you say, watch video, then send link. There's no way around it, I'm afraid. Unless, of course, Accurx decide to integrate their photos into their flurries, which they still haven't done. Yeah, Jacob, if you are still here, that's my request. Yeah. You can't. From an individual patient perspective, as far as I'm aware, and I'm happy to be told, no, you can't. So my understanding is if they've signed up for NHS app notifications, they will get that first. If they haven't opened it within 2 or 3 hours, I think it is, then it automatically defaults to a text message through the system. So it will still charge you on that basis as a text message afterwards. Yes, I know. How long have I got? So yeah, oh, cool. Okay. Did I? Okay. I'm pretty sure I got through 3. Oh gosh, now I'm trying to remember what I said. So top tips for SMSs. Yep. So number one, do the audit in your practice. Actually, more than anything, that will probably save you numbers of text messages more than anything else. Number 2, there are a variety of web links out there that you can use to look at how to shorten SMSs. So I've created one. It's a ChatGPT custom thing that you can do. You can stick your message in, and then you can ask it to put it into one SMS, two SMS, three MS fragments, etc. Recognizing it's approximately accurate. The moment you put web links and stuff into it, that takes into account. The other one to note as well is that Accurx have the default from your practice at the end, which adds a couple of characters as well. So remembering that will be different. Use the character count when you send the message to check and things from there. Avoid emojis, Unicode, all that kind of stuff. Just don't use them at all. Okay, it makes your life so much easier. And to be honest, should you really be sending an emoji to a patient? You know, okay, maybe to our really younger patients, but still, I know they talk in emojis, but we shouldn't really be doing medical advice by emoji. I think other thing is use other types of resources. So the best resource you have in practice will be your practice website. Instead of sending to various different long information pieces and stuff, just simply say, here's a page on our website, have a look here. And the key thing is you're directing them back to your resource that you and only you have complete control over. Every other resource out there, NHS UK, Accurx websites, you know, patient.info, all that kind of stuff, you have no control over the content, you have control over sharing it. Your website, you have total control over that and what is shown on that. So actually use that more effectively. Create the information leaflets on there. You can absolutely dashboard from there to other resources if you want to videos, web links, etc. But use your website as the place to engage with patients. And actually, over time, as they start to use your website, you can then start using that for other stuff like population health management, patient engagement, social media aspects to engage your population more. Make your website the hub for your practice. Yeah. So the question there was about our carbon footprint implications of using SMS over other tools. I think, as far as I'm aware, there's no specific evidence to show either way. The best place I'll probably have a look at is the Green Practice Initiatives from the RCGP, whether they've got information on that. I think the challenge with that is the biggest reason why this is becoming a problem is because it's a transfer of cost more than anything else. So the SMS cost is currently on the ICB budgets. They don't want it on their budgets, and as general practice uses it more, and particularly does what NHS England has suggested we do, which is do total triage, which is use more engagement with patients. Unfortunately, the numbers are doing this, and therefore that's why it's becoming more and more of a problem. I know in my local ICB, their budget was 300,000. Their current spend is 1.3 million. They have to find that money from somewhere. So absolutely understand why our ICBs are saying to us, we don't have the money. In this, they're right. They don't have the money. Should it be funded by the NHS? I think so. I'm pretty sure most people out there think so. But I also hear the comment that actually, as a result of using SMS, practices are spending less on postage. Practices are spending less on other routes to contact patients. So actually, there's a balancing act that is in place there. And also, you're right. What is the green impact? Where is that, tipping point of the tech we use becoming more of a carbon footprint compared to what we used to do before? It's that whole old car versus new electric car thing, isn't it? I don't know. Yes.
Just to clarify, so for example, if you're trying to send a text message to someone on Accurx, you've got the option of sending it to their mobile, and they've got the option of changing if they've got an email address on there. If you switch to the email address, it doesn't count at the time for this cost.
It doesn't count. The only cautionary thing with email is remembering that obviously that email might go into the patient's junk box, etc. Will they or won't they see that? That's a part that you have less control over. It should go to their appropriate email box because it's from a verified, it will come from an nhs.net email address, which are generally one of the most deliverable ones available. But again, it depends on that individual patient settings they put into place. And like I said, it's the urgency aspect. How many people sit there waiting for an email to come in, Compared to an SMS, it's a lot more obtrusive. It does ping up on your phone, and it's a different icon, isn't it? And how many people here have about 6 email accounts? Yeah, how many of you see the different notifications? Actually, it's just number that goes up rather than individual ones. So it's keeping track of it is more tricky. Yep.
Is there a reason why
You can use WhatsApp. You can. Do you want me to expand? Okay. So yes, legally you can use WhatsApp. However, what you can't use is personal WhatsApp. So you can't use my personal phone and my WhatsApp to contact the patient. There's business level WhatsApp that you could use. Obviously, you need a system that then integrates with that as a messaging platform with the patient. That's currently not something that, for example, Accurx provide. Yes, there are other providers. Those providers also have costs that they will transfer across to you to do that as well, because WhatsApp is not free. This is the thing. SMSs are free on a personal basis. All of us probably have unlimited SMSs in our personal phone contract. So you're like, why is it an issue? From a business point of view, it's charged. And same with WhatsApp. From a business point of view, it's charged.
Which would still cost the one brick, but it would still cost one brick. So you could see the long that's it. I need to so there's work going on, but yeah, it would be.
Or smart messaging would be nice. Something. System.
I'm not sure, but it's
It's the same mechanism that iMessage is used, and Apple and Android have their own version of it as well. So basically, it becomes one long. The alternate version is what's called smart messaging, where you send a web link and then it contains all the content within that one web link. So it's only one message that you're sending as a result of it. Either one can work, but it's still an SMS cost. Yes.
I was just going to say, though, the two-factor authentication, Microsoft now doesn't it? So I just thought, Microsoft, obviously, I'm guessing, but doing it that way, keep their SMS charge down, SMS costs. And I just wonder why the NHS we can't negotiate something similar, or is that just not?
They could do. They haven't done. And like I said, yeah, there are some providers that use WhatsApp as a method if you wanted to do that. It comes down to, I guess, the value that has in compensation to some of the other tools that have. Yes.
So say, promote patients to internal notifications for the ultrasound. Then more likely to get the message right on ultrasound.
Yes. There are loads of cool things you can do, absolutely, to encourage the uptake of other routes. And I think they are very valuable to do. And I think realistically, many of you leaving today are going to have to start doing them, because otherwise, the flip side of it is you're going to get charged through another route. I know what my potential bills are for SMS costs moving forward. You know, it's a staff member. That's the cost. You know, it's not, for me, it's not about money. It's about the number of people I can employ. That's the impact it's going to have. And I've said that to the ICB as well. If you put these through, I'm going to reduce the capacity. That is the compensation you get for transferring that cost to me. It's not that I'm just going to suck it up, because I can't. But yeah. Well, let's be honest. We are contracted to provide a service, and it is an unmitigated, unaccounted service that we do. So from my perspective, I think, you know, whenever we are asked to do something more, there's also the question what we stop doing as a result of that. And I think if you're not having those discussions with the ICB and with the different environments that do that to you, then you're shooting yourself in the foot. Because this is the problem that we have had with general practice for many years. We take, and now we've been ground to a pulp as a result of it. And actually the challenge with that is then how do we bring ourselves back into being one piece? The only way to do that is to say no more. And we've done that with collective action. That's got us to one point. The question is, where do we go next now? Finishing? I'll take one more question then.
Scammers and phishing.
Oh, yeah.
Practice set them more and more up through different channels. Criminals are going.
Absolutely.
Or take first into the comms to patients to say this is correct.
So the weird thing is that's part of the reason why we're also having some of the challenges. So I mentioned earlier that SMS is not the most secure method to communicate with patients. That's true because of that aspect, phishing, scamming, etc. that happens. I think there are things we can do. So, you know, having the practice name in the text message, that often is, you know, a very positive thing to patients. You know, having the, you can set particular codes if you really wanted to include that information when you send it to patients. I think trying not to do too much bulk SMSing to patients as well. I know we love it because it helps us do our quaff, it helps us do our reviews, all that kind of stuff. But actually, you know, timing that so it's the same time of day or the same day of the month to provide that regularity to patients, that's possibly something to, and putting that on your website saying that on the 5th of every month is when we will contact you if you have a health need and things. Just being a little bit more transparent about how you communicate and way that you communicate, that can bring more value. But it's a recognized challenge, and it's one of the reasons actually why there's a push away from using SMS with direct patient contact, because it's not as secure as other methods like WhatsApp and other kind of an email and things, because of that aspect. Thank you. Thank you, everybody. I hope this has been a fun and engaging session. I hope for those online as well, it's been great. If you want to check out any of the content, please do so. It's on eGP Learning. All those SMS tips, for example, I've done in a 7-minute video that I've summarized probably a lot more succinctly than I've just done today. And I hope you all have a great conference. And if you want, like I said, we'll have that interview with Jacob later on up on the channel, probably tomorrow, because I need to go home and edit it once I've done it. So if you want to find out the pricing, that's how you're going to find out. Catch you all soon.